Hello, check, check, check. Hello, hello, check. On two, three, four, five, six. Hello, check, check. Hello, 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 check, check. On two, three, four, five, six, seven, eight, nine, ten. Check. Hello, hello, check. On two, three, four, five, six, seven, eight, nine, ten. Hello, check. Hello, check. On two, three, four, five, six, seven, eight, nine, ten. Check. Hello, 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 check. Hello, hello, check. On two, three, four, five, six, seven, eight, nine, ten. hello, check, 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 hello, hello, check,
আরে অন করেছিস? হ্যাঁ বল। মিক্সার পাওয়ার দেওয়া আছে না, সুইচ দেখ। কি সবুজ লাইট জ্বলছে না? হ্যালো সোনুদা, বলো বলো। শুনতে পাচ্ছ? হ্যাঁ হ্যাঁ, ক্লিয়ার। ক্লিয়ার আছে তো? একদম ওকে। হ্যাঁ ওকে ওকে। ওকে তো? একদম একদম। আচ্ছা ঠিক আছে, চেক দাও একটু। চেক চেক। ক্যাশ ক্যাশ। এই ইয়ার কি মেরো না, ডাক্তার আছে। হ্যালো, চেক চেক, 1 2 3 4 চেক।
ঠিক
ওকে।
আছে। So good morning, everyone. So I again welcome you to the second day's program. So today we have, to start with, we have two lectures, three lectures. So Dr. Prabir Rai will speak on basics of linear US, followed by Dr. Bing will speak on poem. Then Dr. Malay Sharma will speak on advances in US, and followed by there is a panel discussion on tissue acquisition via US. After that, we have around 10 to 12 live cases. So without delaying much, I would request Dr. Vikas Singla, he is not yet there, Dr. Vijay Rai and Dr. Kapil to chair this session. And I would request Dr. Prabir Rai to please come here and start his lecture.
Very good morning. I would like to thank Dr. Sandeep for providing me this opportunity. So I'll be talking about linear US, the normal anatomy. So before we go into the anatomy, there are basic principles which one needs to be aware of. One has to review the anatomy as well as the radiological atlases before we resort to imaging. Make the anatomy fit the station. You should be knowing beforehand that if you position your scope at a particular location, what are the structures that you will going to see. And don't guess the station based on interpretation of anatomy. You have infinite number of potential windows when you are scanning with your US scope because of the position of the transducer, the up and down knob, the extent of the clockwise or anti-clockwise rotation that you make. So there is infinite number of potential windows, and sometimes it becomes difficult to identify the structures you want to. So if you are lost, spend some time to find your way, to find the normal anatomy of the home bases. If unsuccessful, start at a familiar location. So the pulse Doppler term is used to distinguish between an artery and a vein. Color Doppler is primarily to distinguish between a vascular and a non-vascular structure. So linear scope, it has got a narrow field of view, unlike radial US, which has got a 360-degree field of view. So it gives you an imaging similar to that of a CT scan, which is not the case with linear US. And therefore, it's very important linear US to adapt a systematic approach to examination. One of the most crucial steps or technique of linear US is torquing. So torque is basically a rotational force, and the clockwise and anti-clockwise torquing is the movement that is used in linear US. And you have to know that when do you say it's an effective torquing. So what you can do is you can see the number on the scope shaft, and it has to be in a 1:1 movement. So what do I mean by that? So if you see this, you're doing a clockwise movement and you see the numbers that are rotating on the scope. So as you're doing the clockwise, anti-clockwise movement, your numbers are rotating in 1:1 movement. So that is what the correct torque is. So very important to know. So for linear US, it has been divided into stations. This is primarily to be sure that you do not miss a particular station or particular area. So what you have is station 1, 2, and 3 is primarily meant to image the pancreas head and the uncinate. This is transduodenal. So you are doing the imaging through the duodenum. So these are the areas 1, 2, and 3 that you want to look for. When you want to see the pancreas body and tail, that is station 4, then you are doing imaging through the stomach. When you are seeing station 5 and 6, it is primarily to image the mediastinum, and the imaging is primarily through the esophagus. So these are stations that you need to remember. If you don't remember the number, what you have to remember is first is transduodenal, then transgastric, and transesophageal. Station 1, that is, you have to position your scope deep to the ampulla. As you can see, the scope is positioned here. Once you are doing this, the most important structures that you want to identify is the uncinate process. And here, your landmark is the aorta. So if you are not seeing the aorta, you have to reposition your scope or insert it further that you see the aorta, because unless you see the aorta, you can't be sure that it's an uncinate or you are imaging the head alone. So this is the first structure that you need to identify when you are doing imaging across the ampulla. So if I show you in video, this structure that is coming up is the aorta. This is the IVC, which you may not see so readily. So once you are seeing the aorta, that means you are across ahead of the ampulla. If you keep on pulling, the structure, that part of the pancreas that comes immediately after the aorta goes down here, is the uncinate. And in this particular case, there is a large mass lesion in the uncinate process. So first you see the aorta. From aorta, you do slight clockwise, anti-clockwise movement, pull back the scope gradually. The part of the pancreas that comes into vision is the uncinate. If you pull back further, you will visualize the head of the pancreas. So coming to the second station, the ampullary, which is usually in an unstable position. Here what you are doing is positioning your scope at the level of ampulla. Once you do that, you see the pancreas in a crescent shape, and you can see the pancreatic duct and the common bile duct seen here, usually in an unstable position. The station 3, that is again you are imaging from the first portion of the duodenum. This station is a very, very important station, because this is the station from where predominantly you will be doing all your pancreatic FNA. So once you position your scope at the apex of the bulb, the structure that you see nearest to the probe is the bile duct. Further from it, you should be visualizing the portal vein. The portal vein is the home base or the landmark structure that you need to be sure of when you're imaging from the apex. And if you see this, you can see the splenic vein coming here, the superior mesenteric vein forming the portal vein. This is the head of the pancreas, and here you may find the pancreatic duct. So if you see the position where your scope is positioned, you can see you are imaging primarily the head of the pancreas, not the uncinate hair. So if I show you a video of the same, so this is a patient where bile duct is not normal. We have instilled a lot of fluid here, as you can see. This is a dilated bile duct. This is the head of the pancreas. This is the portal vein behind it. You can trace this bile duct to the ampulla by doing a clockwise movement. As you can see, we are seeing this is the part of the duodenum actually coming up, and this hole is the bile duct. And as you will see, there is something projecting in the bile duct. There's a small mass at the lower end of the bile duct. This patient still is on follow-up. We did an FNA twice from this. It was negative. And then you can trace this bile duct into the liver also. So you can see you are doing an anti-clockwise movement. You are tracing this to the bile duct, and you can see this is the right hepatic duct that you can visualize going into the liver. So examination towards the ampulla and towards the liver by clockwise and anti-clockwise movement. The station 4, you are doing imaging primarily from the stomach. This is how your scope looks like, and this is how you are imaging. So as you can understand here, if you want to image the pancreatic body and tail, you will have to pull back your scope slightly and do a clockwise movement. So the spleen or the pancreatic tail is slightly above the pancreatic body region. And the first landmark that you need to identify here is the aorta. From aorta, you can see the takeoff of the celiac. You can see the takeoff of the SMA. I will just show you in a video. So if you see this, this is the aorta. This is the first takeoff that is coming from the aorta, which is the celiac artery. And once you see this, you just push in your scope. Once you do that, from the celiac, if you push your scope, the structure that you see is the pancreas. This is not a normal pancreas. Normal pancreas is typically defined as salt and pepper appearance. Here, this particular pancreas has got all the features of early chronic pancreatitis. You can see lobules, hyperechoic strands you can see, and in between you can see a pancreatic duct. From the pancreas, if you rotate clockwise with slight pull of the scope, the structure that you identify will be the kidney. Kidney you identify by hyperechoic center part, which is the cortex, and then the medulla here. From kidney, again, if you do slight clockwise movement, you will see the spleen. So what you are doing is just doing a clockwise movement and slight pull. You are seeing the spleen. This is the part of the pancreas. The tail of the pancreas, as you can see, approaches towards the splenic hilum, where you can see predominantly the splenic vessels. Once you see this, you are sure that you have done a complete examination of the pancreatic tail region. This is splenic vein entering into the splenic hilum. And as you can see, from here, once you have done this, that is pancreatic body, kidney, spleen, you can again go back. If you do that, you can see this is structure, wing-shaped structure that coming is the adrenal. You see the kidney again. You see the pancreas again. Now you are doing an anti-clockwise movement, and then you will see the portal vein confluence here. So this is the portal vein confluence that you just saw. So this is the portal vein confluence, and you can label this. So this is splenic vein, superior mesenteric vein, and this is the portal vein. So if you see this, the portal vein, you can trace this portal vein going into the liver. So you can see this portal vein going into the liver. So your examination is almost complete here. So the last station that you need to be aware of is the station 5 and 6, which primarily is imaging of the mediastinum, and you are imaging it through transesophageal access. So the area at the distal esophagus, also known as area 8, the starting point here is the aorta. Aorta is primarily a linear anechoic structure. So the technique of imaging here is from aorta, you do a 180-degree clockwise movement, come back to the aorta, do 180-degree anti-clockwise movement, and once that means you have visualized whole of 360-degree of the mediastinum, and then further pull around 2 centimeters and continue doing that. You will have imaged whole of the mediastinum by that. So in mediastinum, there are importantly 2 areas which you need to be aware of: the subcarina, or the area 7, and the AP window, also known as area 5. So if I show you this, you have multiple lymph node station, up to 14 lymph node station in the mediastinum, which you all may not need to be aware of. So what is important here is the station area 7. So don't confuse the stations which I had mentioned with the area that now I'm telling you. These are lymph node stations or lymph node area, primarily meant for lung cancer staging. This is the subcarina, that is when the trachea bifurcates, the lymph nodes located at this location is the subcarinal region. The second area that is important is the AP window. So this is the AP window, area 5. So 4L, earlier some considered this to be AP window, but this is left paratracheal area. So 4L is left paratracheal station. This area 5 is the AP window. So how do we see that? So you see, when you are imaging the subcarina, your scope is positioned something like this. You are just, the trachea has divided into right left bronchus. The structure that you see is predominantly the subcarina. This is subcarina, this is the left atrium, this is the pulmonary artery. If I show you that in a video, yesterday I think I demonstrated that in live session. This is exactly the same that we had yesterday. I'll trace the IVC going to the right atrium, keep on pulling back. Once you do this, large pulsatile anechoic structure that you see, that you can bring to the left of the screen, is the left atrium. This is the pulmonary artery. Here you have a large lymph node sitting in the subcarina. So this is the subcarina, where you have a lymph node which you can easily sample. So the other area, as I mentioned, is the AP window. So this is the AP window I'm talking of. So it is the area underneath the arch of aorta. So here you guys, you can see the aorta is arching, and the area below this is the AP window, which is also known as area 5. How does this look like? This is between the pulmonary artery and the aorta. This is the area of AP window. So if I show you again in a video yesterday, again I showed you this. You trace the aorta. Here the aorta starts arching. Once that starts arching, push in a centimeter, rotate 60 degree clockwise. This is the aorta. This is the pulmonary artery. This is station 4L, and this is station 5. So this is what how you can image the AP window. So to summarize, linear examination merits a systematic approach to examination. Make the anatomy fit the station. You need to do effective torquing. I showed you what effective torquing means. Each patient's anatomy is different. Successful and complete imaging may be challenged in some patients. Doing more and more is the key. Thank you.
Thank you very much, Rai sir, for such a beautiful lecture. It is very simple, lucid, but very informative. Anybody who is practicing US, if he learns all these techniques, I think he will be the master of the US. So any questions from the audience? So I just want to ask a question that what are the safety measures you take while doing the linear US? What are the safety precautions you take so that you can avoid the complications?
I think a very, very important question, and the pretext with which this thought may rise that US leads to more complication is probably the diameter of the scope, which is more, the tip, which is slightly different. But having said that, if you see the literature, the complication rate with US is no different from that of other endoscopic techniques. So the complication rate, at least in the published literature, is no different, one. The other important thing that you need to understand, considering you have a probe attached to the tip, so the two concerns predominantly are, one, perforation at the level of cervix, cervical esophagus, one. Second is while you are doing passing the scope from D1 and D2. So these are the two main concerns, and I think with the proper technique that one learns, it's rare that you will have any of these complications. If you are passing through any structure and you have a resistance, like in esophagus, if you pass your US scope, if you have got resistance, don't push in the scope, take out the scope, do an upper GI, just ensure that there is no stricture, there is no diverticulum. If there is an elderly patient, only then pass in the scope. So if you have a free, no resistance in the scope going, then only push in the scope. Don't push it blindly. Don't apply too much of pressure if you have resistance. And with the proper technique, I think these complications are more theoretical rather than the practical.
Thank you very much, sir. So if there is no question, then we can move to the next lecture. It is by Dr. Hugh Bing on poem. And we all know that poem is coming in a big way for treatment of achalasia cardia. So I request Dr. Hugh Bing to start his lecture on poem. Thank you very much.
Breakfast is served at the back, so please help yourself. Breakfast is served.
sorry, my computer is old. I have no money in my, buy the new computer. Yeah, sorry. Ladies and gentlemen, good afternoon, good morning. My name is Hu Bing from West China Hospital, Sichuan University. Today I am ordered to give you my presentation, talk about the poem. So today we talk about the poem. Is one poem, traditional slang about. Second is the old poem. Third is dual poem. First is D poem. The poem have the five, and the G poem. The standard poem and the G poem. Standard poem is Japanese expert Iloi, Professor Iloi innovation. But I didn't know G poem is who is innovation. But I know O poem and dual poem and D poem is my innovation. English is sometimes include dysphagia, retinal pain, and regurgitation. This is the endopathic manifestation. Treatment is oral administration and balloon surgery, poem, and old poem and dual poem and so on. If I do poem, step 1, create the mucosa entry to the submucosa tunnel. We locate the 8 to 10 centimeter proximal to the cardia. Usually on the posterior wall of the esophagus submucosa injection, followed up by the 1.5 centimeter incision of the mucosa. If the entry is small, in the tunnel have no air, didn't drainage, so is due to the ceramax. Submucosa tunnel, dissection mucosa, tunnel downward about 3 centimeters into the gastric fundus. It's tunnel. It's fundus. Yeah, we show the fundus. Cerebral 3, it's myectomy. So if the tunnel is building, we incision the muscle. It's second muscle and the non-tubular muscle. So one method we only incision the second muscle, and two methods both of muscle, second muscle and the non-tubular muscle, both of the incision. This picture shows both of the muscle be incision. The last step is close of the mucosa entry. Close the non-tubular by the clip, the tuber placement if low retinal need. So this we close, use the clip that close the entry. This is the magnet of the intraoperative complication. If they have the complication, because example, the mucosa have the injury, we use the clip close. If they have the pneumothorax, we use the lead aspiration or close the drainage. Just command we use the needle aspiration is good, is enough. If they have the pneumoperitoneum, aspiration at the point. Now, introduce my innovation, open, dual poem, and deep poem. Poem. The poem word is entitled The Meaning of the Title Technique. From the under the protecting the mucosa, even if the perforation occurs. Why? If there is no tallow, why? So this barren examination is catheter is tight. We incision the mucosa, incision the muscle. Is founder. So these three pictures show the follow-up. Follow-up. The cutter is open. Junction is open. So we see here is the scar. Is the scar. Now this video shows the open process. This injection is very tight from the 20 centimeter injection same to slender palm incision in the mucosa. Until now, gastric. Now, this incision, the mucosa. Close the injection. Here is tight. This just here is difficult. We can clear the incisions where, if in the tallow, sometimes I didn't know where is the injection, where is the gastric. But in open, where the pollution is clear. Just this is non-tubular muscle. Here is non-tubular muscle. So both of the muscle, incision is non-tubular muscle. So here is low muscle. Now the catheter is open, injection is open. Here is low muscle. Mucosa is after 1 week follow-up, just ulcer. Yeah. Here is ulcer. It's 1 week, after 1 week. You can see. It's 2 week follow-up. The ulcer is smaller. Is smaller. Yeah. So 1 month, after 1 month, need just the scar, the hair, yeah, here, yeah, it's there are over 18 cases of the open in my hospital. It's no severe complication occurred. One patient have this. The patient started to have the liquid diet on post-operative day 3 days. Post-operative hospital stay 3 and 4 days, sometimes significantly relieved. Now, Fisher, we studied open indication, country indication, complication, safety, long-term outcomes. Oh, okay. So it's advantage of the OPOM. Direct the focus myectomy. No tunnel, so I direct the focus. So no tunnel, this infection related complication. Wide field within, easy to control the bleeding because the space is big. You need to judge the location, just I say it, and announce the way when you cut. Allow for processing myectomy. Shorter operation time. Maybe 10 minutes can be finished. 10 minutes only. And low cost, lower cost. No treatment operation of agriculture. Maybe. This is my the open published journal. Now I introduce dual POM. Background: the agriculture use the traditional POM to do. Presence of the recurrent symptoms may occur. The midterm recurrence time 6 months. Recurrence rate 18%. 18% is more. It is recurrence rate is more. Yeah. The clinical problem maybe the incomplete myotomy, and only thing myotomy is not enough. During the single procedure, do myotomy to avoid the repeated intervention. So I name the technique dual POM. Now, this patient is 50 years old. This pre-operative is ventrography. Just here is the stretcher. Same POM we built in the opening. This tallow. At least half of this is ventral lumen. The tallow is big, bigger than traditional POM. Now, do myotomy in the 5 to 6 o'clock and 1 to 2 o'clock position. That's here. It's here to do myotomy. It's do myotomy. It's muscle. Just it's muscle. Here is no muscle. No muscle. It's mucosa. It's mucosa. Now, so as next step is use a clip that close the injury. So it's follow up after dual POM 1 month. It's after dual POM is 8 months of the Barber's bone. Yeah. No reflex. So read out the 40 cases of dual POM in my hospital. Yeah. It's dual POM is published in the endoscopy. Dual POM. Yeah. Dual POM. Yeah. Here is dual POM. Last, I introduced my innovation D POM. The D diabetic column. So I show the photo is ventral diabetic column. Here is diabetic column. It's esophagus. The original photo. Yeah. Intron. Building the intron. It's tallow. I built in the tallow. I find the septal wall. This is septal wall. Not clear. The septal wall is clear. Yeah. So I incision the septal wall. This no complete incision. The septal wall cut down. Yeah. So last they put the same POM close use clip close the intron. So this post-operative, and you can see the septal wall is slide down, and the mucosa is smooth. No residual fold. The Barber's syndrome is the diabetic column. This is the speed of the quickly strategy. So my previous is try. I recommend. The lot of is beautiful in my home. It's the Huang Long, very beautiful. Zhou Zai Wedding. Zhou Zai Wedding in China is the best, beautiful. Yeah. From Qingdu, in my city, go to a Jordan, maybe 1 hour of flying. Yeah. But I didn't go to Jordan because I'm busy, working busy. And mountain, only mountain, no sun Buddha. It's Buddha is biggest in the world, biggest in the world. Its mount is Buddha. Its mount is Buddha. Yeah. Qingchen Mount, Qingchen Mount. Yeah. Panda. Panda, the famous animal panda in Chengdu. In Chengdu. So, hot pot. Welcome to China, welcome to Sichuan. Thank you.
Thank you, Dr. Bing. It was a very, very informative lecture because we are always worried about the tunnel. And in O poem, there is no tunnel. So the whole thing becomes so easy. But we don't know about, we are still skeptical about the complications that if there's no tunnel, then there's maybe chance of infections and pneumothorax and all these complications may aggravate. But you have shown a very good safety profile in all these patients. So it's really amazing, and we should also try practicing this. So any questions from the audience?
Bing, that's an excellent presentation.
Thank you.
Your valley is beautiful. Yeah. And I have just 2 questions. First is regarding a dual poem.
Dual poem.
Yeah, in that you are making 1 tunnel and 2 myotomies. In 1 tunnel or 2 tunnel? 1 tunnel.
1 tunnel.
1 tunnel.
1 tunnel.
Yeah.
1 tunnel. Some of the published article in the published research. The one article is double poem. Is to the one time poem, but the patient persist. But I next time do the poem. Yeah.
So, what is the rate of reflux, GERD, after dual poem? Will it increase after the dual poem?
Yeah. Now we process total 40 cases dual poem. Now no severe reflux.
Okay.
But the cases is less.
So you are doing dual poem for every patient, or you select the patient for dual poem? So how do you select patients? For
Now we select the severe, the dilation the esophagus.
Okay.
I do the dual poem.
Okay.
Yeah.
And one is regarding open O poem.
Open.
So you cut both circular and longitudinal muscles, or you cut only circular muscle for the?
So half of the cases, in the 18 cases, now I do the 18 cases. So half of the cases, I do the only circular muscle.
Only circular.
Remain non-tubular muscle. Okay. Another half of cases, we do both circular muscle and non-tubular muscle.
So why there is no leak after the O poem? So what prevents the leakage in mediastinum? Why there is no leak?
No leak.
No leak. Why there is no leak? So is the adventitia protecting against the leak in mediastinum?
I first time do the open, I'm surprised. Why? Because the tunnel I didn't build it, so I do the open. After open, I surprised the patient's condition is well. I saw the body, the person's body is strong, very, very strong. So I didn't know more long.
Dr. Bing, one question is there. How is your feeding protocol after normal poem and after O poem? It's different. Do you keep more NPO after O poem?
Feeding after poem.
Feeding after poem, it's different in O poem, or it's same?
Feeding.
Eating, yeah.
Eat. Open, I think after open 3 days or 4 days.
3 days patient should be NPO after. 3 days NPO, patient should not take anything.
Okay, 3 days.
And in normal poem, what is the protocol? Next day.
72 hours fasting. Nil by mouth.
For 3 days.
3 days.
In O-poem, where do we give the mucosal incision? Above how much centimeters above the G junction you give the mucosal incision in O-poem? Like in routine poem, we start the mucosal incision around 10 centimeters proximal to the G junction. In O-poem, which is the site of the first incision, around how much centimeter above the G junction?
Length of myotomy.
Oh, length of myotomy. So same the Chinese poem. Chinese poem have the standard length as 10 centimeter talo, and the short talo. And old poem is the same and 10 centimeter length and short. Yeah, same. Yeah.
So, thank you very much. Now we come to the next lecture. Thank you very much. For the next lecture, I would like to invite Dr. Malay Sharma sir, who is a senior gastroenterologist, and everybody knows him. He's pioneer of US in India. So next lecture is about the advances in US. So Malay Sharma sir, please.
So I went to Dr. Hu Bing, and so some of the language in Chinese, so this I have included so that he can understand. So submucosal tumor is his specialty, and there is a role. So why is it needed? Because today 20% cases of EUS articles are related to EUS, and it is the interface of PRCP-ES. So how do we show the progress? So I will mention some of the advantages. Now for the example, this is a video which shows that you are puncturing the mass in the pleura. You can puncture a pleural mass, and in this case it was easily punctured. It was deposited on the mediastinal aspect. So then another case in which there was exertional breathlessness, pericardial effusion, pericardiocentesis, and this was a CT scan showed tumor in thorax, and then endoscopic ultrasound was done. So there was a mass, and this was the mass here. This is the pericardial recess. This was the mass, and these are the effusions. These are pulmonary veins, and then this pericardial mass FNAC was done. So this FNAC was possible from this mass, and this was 22 gauge FNAC needle puncture, and the diagnosis of a mesothelioma was established. So what is the basic principle is, if the vessel is blocked, you unblock it, and if it is unblocked, you blocked it. Means thrombosis. So I will mention some of the EUS guided interventions, some. But I was just told that this is a case of Dulafoy ulcer, and sometimes you may fail to pick up a bleeding point, and if there is a Dulafoy ulcer, you can pick it up. This is another case where there is an aneurysm, hemosuccus pancreaticus. What happened when we were trying to find out the role of endoscopic ultrasound, reading new things, the only thing that was coming our way was bleeding, where we were unable to find out. So wherever there was obscure bleeding, we were looking for the source, doing endoscopic ultrasound, and then we discovered over this period the hemosuccus pancreaticus. Now this is come the diagnostic part, but there is a therapeutic part, and what I mean to say, when you see all these vascular structures, you can start imagining what you can puncture by EUS. And I believe puncturing all these vessels is not a problem. So what we have been able to puncture so far is inferior vena cava. We have been able to puncture the atrium, left atrial mass. We have been able to puncture the pulmonary cardiac chambers. We have been able to puncture the inferior vena cava mass. We have been able to go through the aorta. We have been able to puncture the gastroduodenal artery. Gastroduodenal artery, we have been able to enter into aneurysm which are around here, and we have been able to enter the entire portal venous system by puncturing. So most of the vessels can be punctured. So what about aorta? In this case, there is a mass here beyond the aorta, and what you have to do is just go through the aorta and you puncture it. The tricks of going through aorta is always go through the middle part of aorta. Your trajectory should be in the middle part. Now this is a simple diagnostic issue where there is thrombus in the portal vein, and in this case there was an issue whether the thrombosis in portal vein is due to malignancy or whether due to extension of a benign procedure, but FNAC confirmed that this is malignancy. Now this is a case where there was mass in the inferior vena cava, and this case presented a rare presentation of a hepatocellular carcinoma, and then I think I will need some. And in this case, the biopsy was done. Power. So we were able to do FNAC of this mass. So a small mention about generally because varicose bleeding, and we can do in varicose bleeding, and then about coils. Coils, how to block vessel by coil or microcoil. These are coils and microcoils. So these are the submucosal varices, which yesterday there was a confusion, where are they? So submucosal varices are these muscular layer, and these are the classical submucosal varices, and then these varices can be punctured, and in this case you will find out that these were a couple of the initial mistakes that we were making. We were not measuring the size of these varices, and then we were putting in coils, and you can see this particular coil is smaller than the diameter of this. This smaller diameter coil will be mobile, and it can even go out through these perforators. Then we started putting in bigger coils, which will stay in the place inside the varices, and then these bigger coils we can put in. Glue one coil, so two coils, and after the coil we can push into the circle. So this is the end result is blocked varices, and yesterday we have shown when the varices are blocked beyond this point you cannot see because the varices are obliterated. So then this is an example of what is bleeding in the rectum. So initially to an observer it may appear as a case of Dulafy ulcer, but this is not Dulafy ulcer because when you do endoscopic ultrasound you find out that this is a submucosal rectal varix which was banded, and interesting thing is a reappearance of bleeding above the veil. And what is this reappearance suggests that it is a case of again rectal varices, and it was rebanded, and the blood flow in rectum is from above downward. So you must do rectal varicose bending from above downward. So now the non-varicose bleeding, this is a case of periampullary tumor. It's presented with massive bleeding. We could not stop the bleed, and this showed periampullary tumor. And then we were able to try injecting. This is the course. We went into the duodenum, and we were finding the vessel going close to the duodenal wall to this tumor. Initially we tried injection of alcohol into this area, and this alcohol has gone into a vessel, but this failed to stop the bleeding. So then what was done was we kept zoomed more, and this is the gastroduodenal artery, and this gastroduodenal artery was identified, and then it was punctured, and this is the puncture of the gastroduodenal artery. And after puncturing this is your dye going into gastroduodenal artery, and after puncturing this, then you can place coils into the gastroduodenal. These are micro. This is the coil which is moving in the gastroduodenal artery. This coil provided satisfactory. This is not a common instance, and when we operated, these coils were removed from the surgery, and that is how these coils came out when the surgery. Sometimes you could have massive bleeding requirement. Pseudoaneurysm, already Dr. Rai also has published a lot about pseudoaneurysm, and he has probably standard care of treatment is there, that splenic artery pseudoaneurysm. You have to. So what is this is one of the cases of pseudoaneurysm where you are seeing here, and this pseudoaneurysm there is a lot of yin-yang flow, and what you can do is inject into this, inject cannula, and then inject more coil or glue. Three things can be injected. You can inject, one is a coil. Second thing is after one coil, second coil, because the coil tends to go away into the farthest part of the vessel, and then finally you have to inject some glue or some thrombin. So you have multimodality combined imaging. So some people put in coils, some people put in glue. So we have done about 10 cases so far, and we are in the process of finding out what is this. This is a giant. What is giant and pseudo is beyond a size. If it is 6 centimeters, this is a giant. It appears as a very slow flow, and sometimes before and after thrombin injection, this particular case was managed only by injection thrombin. We kept on injecting and injecting. So then this is unblocking the vessel. And this thrombolysis of portal venous system is possible. And this is a case where there was thrombosis of the splenic vein with severe dilatation of the splenic vein. And what you did is CT scan also showed thrombosis of the portal venous system. And then you did, this is the MRI which showed there is a Y-shaped, horseshoe-shaped thrombus extending into the superior mesenteric vein, portal vein, and inferior mesenteric vein, in the left gastric vein. This is an entire thrombus. We could put in a needle into the thrombus and then advance a guide wire from the thrombus through the thrombus into one of the tributaries of portal venous system. And this is how the guide wire, the needle was placed, and then the guide wire was placed, the needle was removed. After removing the needle, we were able to place a dilating catheter. It is not easy to dilate portal vein, but a tapered catheter of cannula, tapered cannula over the wire was able. And we used 0.018 guide wire, and then the guide wire was confirmed that this is under portal vein, and then we were able to confirm the position by endoscopic ultrasound also that the guide wire was within the portal vein. And then the guide wire was left in place, the cannula was removed, and the dye was injected, and this dye is showing a study of portal venogram through the EUS guided portal. Then this scope was fitted, cannula was fitted through the nose with a syringe pump, and streptokinase infusion was started. And this streptokinase infusion was continued for 3 days or 7 days. This is the patient's follow-up, that these are the thrombus. The thrombus is still there, but the patients who are going originally is having a hard, tough time, impending gangrene. This is now published in American Journal of Gastroenterology, that they have been able to do pulmonary artery thrombolysis, EUS-guided pulmonary artery thrombolysis, and this was a pulmonary artery thrombus. Systemic coagulation was contraindicated because the patient had a recent history of hemorrhagic stroke, and he had a mobile thrombus in the right pulmonary artery. So once we found the mobile thrombus, we were able to, 65% lumen was occupied, and then we were able to puncture into the pulmonary artery, and this is the pulmonary artery being punctured. Initially, thrombolysis was offered within the thrombus, but then we decided we can offer it even outside the thrombus, because part of the thrombus effect is going into the branches of the pulmonary artery. And then this is the follow-up after 48 hours, that this is infusion into the side branch, within the thrombus and outside the thrombus. So this is how the thrombus appears soft, mobile, and within the upright pulmonary artery after 48 hours. So coming toward the last part, because there is some unusual indication, but this is a case where there was calcification within the pancreas, this stuff, and we are unable to. So though there may be controversy regarding management of such cases, but the pancreatic duct was punctured from the duodenal pulp, and this is how a guide wire was found. We Because we foresaw that in this case, the removal of a stone or lithotripsy is not going to be possible, and this cholangiogram was done, and then UV guided puncture of the pancreatic duct was done, and a dilator was placed into the pancreatic duct, and subsequently. So in my opinion, this placement of a pancreatic stent is something like formation of a new papilla for the pancreatic duct. But again, this is a topic. Many people will do it in a different way. Lastly, just to mention that we are doing something new. Omental deposits are one of the important things that you can do biopsy from and ovarian masses. So we are in most of the things in gastroenterology. Sometimes you may need to do FNAC of ovarian masses. So thank you very much.
Thank you very much, sir, for a nice demonstration, nice lecture. And I just want to just have one question that if a mass is lying below some artery or vein, that what precaution you take to avoid bleeding or any other complications?
See, when it comes to doing a logic, you want a diagnosis. So when there is an indication for a diagnosis, there is no contraindication of the procedure. For example, when you are going to put in a central line, you are forced to put in a central line because you don't have any access left. Now central line is like a venous puncture, a blind puncture, a puncture at least 3 centimeters away from the surface and with a bigger catheter. So logically think that way, that if you can puncture the jugular vein without application of significant pressure, you can puncture everything. That is first step. Second, arterial punctures are safer than venous puncture. Artery will recoil, may not require vein. But in arterial puncture, if the size is big, be wary. Don't go through the atherosclerotic plaque. Okay. Third is cardiac punctures, no problem. Aorta puncture, arterial punctures, pulmonary artery puncture, gastroduodenal artery puncture. Generally, all these punctures should not be a problem. Aneurysm puncture, no problem, because the wall is, because this is much safer. Initially, you are scared going through, but aneurysm has such a slow flow. You will just put in, inject, and you will see. Okay.
Thank you very much for your tips.
Sir, you said that once you are transversing the aorta, you go in the middle of the aorta. Any particular reason we want to avoid some tangential force or some sort of a coupling force so that we go take the needle in the middle of the aorta to approach a mass beyond the aorta to take an FNA?
See, either you should go 3 ways: above aorta, below aorta. Suppose there is a mass lateral to aorta. Either you should find a pathway above aorta through the vessels between subclavian and common carotid artery. If you want to go through the aorta, then try to go adjacently through the middle. The axis should be, because if you go from side, there can be one of the complications, shearing of the wall. Below the aorta, interesting. You do fully up. No? You fully elevator up, and then try to go between the aorta and pulmonary artery through the window. So you go near the lower edge of the aorta, through the aortopulmonary window, and then go lateral to aorta. So 3 ways to enter structures lateral to aorta.
Well, excellent lecture. You mentioned thrombolysis of portal vein and the pulmonary artery. Portal vein, it's difficult to reach by other routes. You have to go to transhepatic puncture. That's very risky. So EUS guided modality can be a good option. Regarding the pulmonary artery thrombus, you can enter by the jugular vein, right atrium, right ventricle, and you can enter the pulmonary artery. So is there any real need of doing EUS guided direct puncture?
See, there are number 1 alternative modalities. Yes. You work in an atmosphere where pulmonary artery can be thrombolized.
Okay.
I want to ask how many of others work in an atmosphere where pulmonary artery can be thrombolized. Varun, your hospital? Can you have pulmonary artery thrombolysis at 12 o'clock? Yes. Difficult. SGPGI,
okay.
It can be done. So I believe out of 15 people doing endosonography, okay, only 2 have access to emergency pulmonary systemic or catheter guided thrombolysis. And pulmonary embolism thrombosis is a big killer. I don't have access to it. So the need is one thing. The availability of EUS is probably going to be far more than the availability of intervention radiology in near future. And that is why we must be prepared, because we will save many cases by offering them pulmonary artery thrombosis.
And you will leave a catheter inside the portal vein?
No, in portal vein. See, in portal vein we have done now around 10 cases so far. Sometimes we are leaving. When we are leaving, we are having problem of bleeding. We are managing by pressure. Tamponade by a GI balloon or tamponade by the tip of the scope. We are also ready to inject thrombin outside the portal vein. Inside portal vein, thrombolysis. Outside portal vein in the tract, thrombotic agent. But that is what we have been thinking, how to stop it.
Or other option can be you do EUS daily and see the thrombus inject daily rather than leaving a catheter, repeat EUS at multiple intervals and then...
That is an interesting, because what is happening, we are giving them anticoagulants, trial of anticoagulants sometimes. You try. If the patient is improving or not improving, generally EUS guided thrombolysis is reserved for those non-improving group. And in those non-improving group, or you know that this patient in your mind is not going to survive if you don't do anything, or is it desperate, or there is already established gangrene in the vowel. You have to salvage the gangrene. So, or the acidosis is there, high LDH, all those things. So, in those cases, you do. And once you have given it, then you are going to follow it by low molecular weight heparin. So, once you have followed it by low molecular weight heparin, probably the chances of daily puncture and repuncture complication may be higher. But these patients are already high risk group.
Thank you.
So, I think if there's no questions, then we can close this lecture sessions and we move on to the next by Dr. Sandeep Pal. He will start the...
So the next session is a panel discussion on tissue acquisition by US. So I would request Dr. Gaurav Chawla, he is the moderator of the session. And I will request the panelists to please come on the first row. So Dr. Vishwanath Reddy, Dr. Pratap Mouli, and Dr. Avinash, Dr. P.P. Bose, and Dr. Pravir Rai. I would request Gaurav to finish it within half an hour. Sorry for that, but we need to start the cases. So.
diagnostic and staging algorithms in GI and associated organs, and we can acquire
Yeah, most common we have is pancreatic lesions, masses, inflammatory or neoplastic when there is a doubt, and we also have lymph nodes, abdominal as well as mediastinal lymph nodes. These are the common sites.
And apart from that, I think liver as well.
Yeah, we also have other.
Mediastinal lymphomatosis, or sometimes
Yeah, when there is.
of pancreas.
Yes.
And Dr. Pratap, what is the like for subepithelial lesions? What is the protocol? Do you sample them, or you just follow up, or depending upon the lesion? What is the protocol?
So most of the cases we don't require sampling, but the practice in our state is guided by the state insurance system, where to enter the insurance system, most of the times you require a tissue diagnosis. So if the patient is going to the state insurance scheme, I do an FNA. Otherwise, standard of care, if he is a paying patient, I go by the textbook. So most of the lesions I don't sample.
Sometimes surgical oncologists will ask for tissue diagnosis because they will have to give imatinib and the size can decrease, thereby the resection margin can be lesser. But most often if it is operable lesion, they generally take it out. Yeah.
But again, even the surgeon goes by the insurance schemes most of the times. Like they need to apply for an insurance, they ask for a tissue diagnosis. That's how it works mostly.
I think it's very important for subepithelial lesion to know exactly how big the lesion is. So, and depending upon the size of the lesion, depending upon the location where it is situated, that will primarily dictate whether you need a tissue or not. Like in esophagus, say if you have a 1 centimeter lesion, you are suspecting it to be esophageal leiomyoma, probably you need to just follow the patient up, you don't need anything. If you have a 3.5 centimeter, 4 centimeter lesion in the esophagus, which you're assuming based on imaging to be a leiomyoma, the surgeon will usually not need a tissue diagnosis. So I think in these scenarios, if there is some doubt about diagnosis, only then possibly you need an FNA.
Sir, but where do you find it? Where do you find such a doubt? What is the clinical scenario where you find a doubt and do you do an FNA?
So recently we had a very interesting patient. It was presented in a radiology round. So they did a CT scan, and on CT scan the suspicion was esophageal leiomyoma. And when the surgeon operated upon it, was a duplication cyst. So everyone was after the operating team that why did not you get it a EUS and FNA, at least an EUS done, though EUS was not included in the protocol in that particular setting. So I think what is the specific question that you want to ask?
No, where do you find an indication where we need sampling, not just EUS, for subepithelial lesion?
Need sampling?
Yeah, where we have a doubt.
So I'll give you the scenario. So you have a 45-year male, and the patient you diagnose, like I at least have 2 patients on my follow-up. So lesion in the esophagus around 2 centimeters. You tell the patient that there is nothing, it's just esophageal leiomyoma, nothing else. The patient wants a tissue diagnosis. He wants to be sure that he's not dealing with anything malignant, because whatever you say based on imaging, unless you have a tissue diagnosis, you can't be 100% certain. So in these scenarios, you may end up doing an FNA and convincing the patient, at least the patient also gets convinced that, okay, so this is the diagnosis and I need not worry. So for that, sometimes you need that.
Personally, I had one case where it was I think submucosal. I thought it's a carcinoid. I thought it's a pancreatic rest, because I could see some hypoechoic, anechoic lesions in it. But it turned out to be a neuroendocrine tumor. That's the only thing I could see. Yeah. Reassurance, yes, but apart from reassurance.
Yeah, needles, actually, there are basically three types, 19 size, 19, 22 and 25. So these needles actually are selected according to the position. Actually, if it's in the esophagus, the scope is quite straight and you can go in with a 19. And in the stomach also, you can play around with 19. You get good samples. For therapeutic procedures, you need 19. In the duodenum, there's a problem, you know. We have to go across a curve and 19 will not work. I'm leaving aside the Flexi 19, which is now available. 25 is, you know, easy to go in. So 22 is in between. So 22, of course, Gaurav, I think he will talk about these studies.
Yeah, I think as sir told, for duodenal lesions, 25 will be better because in a lot of studies are also shown that 25 G is better, best for transduodenal lesions. As sir told that region scope will be straight and we get a fairly diagnosis by 22 gauge. But transduodenal, as Dr. Pravir has yesterday shown that scope was in curve position, then normal needle might be difficult. So 25 gauge will be better for, I think, transduodenal. So based on this, one simple algorithmic approach is there, like for diagnostic procedures. If you have a transduodenal 25 gauge needle or other routes, you do 22 gauge needles, and whenever you are doing interventions, cyst aspirations or biopsy, you do standard 19 gauge or flex 19 gauge. So based on this algorithm from Dr. Shyam from Florida Hospital did studies. During phase 1, he used 19 gauge and 22 and 25 gauge, and during phase 2, he used this algorithm. So what he found out that technical failure rate was just significantly better when they used this algorithmic approach. Failure by root, by the stomach, duodenum was significantly better. Failure by needle rate was 1922 was significantly better and was most cost effective study. So, Dr. Reddy, do you use suction or no suction?
So usually I avoid using suction because it tends to be a hemorrhagic sample. So only in patients with chronic pancreatitis, sometimes with a mass, I use suction. Otherwise, generally, suction is avoided.
Okay, what about others?
Yeah, lymph nodes and all.
Yeah, basically, like when we pass the needle, we get to feel the tissue. Like if at all it is hard, definitely like we use 5 to 10 ml of suction. If at all it appears small, then definitely no suction. Nodes, definitely no suction.
Yeah, I think two things. One is personal experience and another is literature. So personal experience, first pass, no suction. If no material, you use suction. And literature, I think you'll be talking of. So what the literature says is ESG guidelines, they clearly recommend to use 10 cc suction, especially for pancreatic solid lesions.
So most of the studies told that it will increase the bloodiness. It also increases the bloodiness of the sample. Some studies have shown that diagnostic yield will be better. As Dr. Pravir has said, in pancreatic lesions, and if you're not getting a material on first sample, then you should use suction. So others, most of the time, studies have shown like they have shown that it increases the bloodiness of the sample. Now next is stylet or no stylet, Dr. Pratap.
Yeah, usually the first pass it comes loaded, so I use stillet in the first pass. It depends if the material is good. I'm doing it quickly. I don't use a stillet. So either way, it doesn't differ much. It doesn't affect.
So literature is also straightforward like that. It doesn't affect the diagnostic yield, but it may increase the bloodiness of the sample in various studies. So stylet or no stylet doesn't make much difference. Now, coming to the sampling technique. So, what sampling technique do you prefer, Dr. Bose? Standard or fanning?
Of course, for pancreatic mass or masses, fanning is definitely better than the standard technique because you can sample the tissue as a whole from all aspects as much as possible.
And Dr. Reddy, do you use any special techniques, capillary technique, wet section, or normally just whatever it comes you put in the slide and make?
Yeah, regular technique only. This slow pull technique I use sometimes, but this capillary and wet section I didn't.
So I think for all practical purposes, fanning is the way to go. However, this is the only randomized control trial what you have put up which suggests that fanning is better than the standard technique. Only one RCT, no other study. But I think it makes sense. You are sampling majority of the lesion rather than passing through a particular area. So other technique I think we'll be talking of is a multi-pass technique.
Multi-pass technique, Dr. Anand Sai recommends like multiple punches, but that is also like same like fanning. Only thing is comes out of the lesion and then go in multiple directions.
So the difference in multi-pass technique is if you are doing a fanning, so your point of entry is same and there is a limit to which you can fan. However, if you are doing a multi-pass technique, you are moving entirely to the different part of the lesion. So theoretically, obviously, you will have more of the lesion sampled with a multi-pass technique compared to fanning technique. Having said that, you don't have any in trial. So I think what I would...
Contamination in multi-pass because you're coming out of the lesion. GI contamination will be more in multi-pass.
Yeah, so again, as I mentioned, these are all theoretical concerns that one has and which is logical. So what, if you read the multi-pass technique, what they recommend is just come out of the lesion and then again enter, just out of the lesion. So how, to what extent it does contamination, again, no one has studied that. But I think fanning is the technique that one should prefer. About the capillary suction or the that you have put up, so you have different techniques. You just apply dry suction or what you know.
To 4 needle passes with the FNA needle. So that is the recommendations. So Dr. Praveen, what is your take on operator experience and those field of FNA? You are in a training center like.
Yeah, so we tried very hard for pathologists to be on an endoscopy room for all cases, but unfortunately we could not achieve that despite being in a tertiary center. So having said that, initially we had maybe the yield was just 60-70% when we started doing FNA. But right now, even without the pathologist in place, the yield is maybe more than 95%. So I think operator experience is very, very important. And if I don't remember exactly the literature, but we have a recent study which says that with or without rows, it's not important. It doesn't make a difference provided the experience is good.
Yeah, so I think initial studies when everyone started doing US, it depends upon the experience. Definitely, if you have a less experience, your learning curve will be more. Your samples will be like you will have 60-70%. But as you become more proficient, more cases, then you will get more than 90%. So some initial data came on on-site pathologists, I think, but even for Europeans and Americans, it's difficult to have an on-site pathologist in room because of logistics. So this initial cases showed where on-site pathology and number of cases became important.
This patient, no, stop. The patient no sedation.
No, we are not doing.
Huh?
He's just checking.
Just checking. Yeah.
He's checking.
Okay.
Hello, check. Hello, check.
So number of passes required for you become more efficient, you become more expert, so less time consuming, you get
Scary Here is an O poem.
Just wanted to ask Dr. Praveer, do you yourself see the cytology samples in between? Because, you know, that was what Dr. Sham used to do. I mean, he was very good at cytology. So he used to go in and have a look himself, and, you know, that's just a replacement of an on-site cytopathology.
Yeah, so I think that possibly makes sense, but I don't do that. I don't practice that.
Initial studies told that diagnostic yield was better if you have an on-site pathology, indeterminate samples as well as unscientific samples. Various studies came in 2012, 2013 which showed that on-site pathology is better. If you have on-site pathologist, FNA will tell them, but if you don't have, then you need additional material. You should always use cell block and or otherwise FNA. So you use Dr. Praveer, cell block for each of your patients.
Oh, cool.
If you don't have
So not in all. So it depends upon the possible diagnosis that we are thinking of. So if we have a suspicion of GIST, if we have suspicion of lymphoma, obviously in those patients I'll make a cell block, because what you need is an immunohistochemistry. Even if you make a diagnosis, then you can't do IHC on cytology alone. So you need a cell block in those patients. So not in all, but obviously where the differential diagnosis of GIST, lymphoma is there, you need cell block.
In the conference room, your colleague, please state your colleague. If I do the name demonstration, give me photo. Give me some donation. You are listening. Yeah, okay. Thank you.
This is the latest trial in 2018 from Dutch people. They have assessed 41 in each case, rows or no rows, based only on lymph node regions. And this also diagnostic accuracy as well as diagnostic yield is same, whether you have rows or you don't have rows. So diagnosis, most of the time, more than 90 to 95% you will get if you do a good FNA. This is the trial which is now in 2018 randomized trial. So if you see diagnostic, it is close to 99%. If you use suction, no suction,
yes, my code,
is 92%.
Yeah.
All other
Just
things
my
is
code.
98, 99%.
No.
So, but
My
FNA
code.
has some limitations. So, if you have a rose, if you are comfortable that you have excellent. But if you don't have a rose, cell block, what is the yield of cell block?
Yes, yeah. Okay.
Each time
Marcos, yeah, well, please.
Yield of cell block is
Yes.
also less.
I think both the FNA and the cell block are complementary rather than which is superior or anything. So as Dr. Praveer has said, like it adds on for the IHC and all. So Mencken cell block doesn't give a tissue.
Sometimes it happens that they say that sample is inadequate because it's difficult for if that happens to repeat a procedure is difficult. I mean, no administration.
Yeah. So I think one or two things are very important to realize is US FNA and even cell block may not be every pathologist cup of tea. So every pathologist may not be able to give you the same report. So what we have done in our center after now recent with the last 6 months or 1 year, we now have cell block in our HIS system. So, but the problem is my FNA turns out to be positive, but the cell block turns out to be negative. So that is a problem that I'm encountering recently. And the reason, one of the reason may be the expertise. when I get it
As you told, that it's very important, like they need a board certification in cytopathology, which I think India doesn't. They found difficult to introduce, and they need a histological specimen that is easier for them to just see the cells. Like my pathologist initially also, we have to make them tune and just see for the cells. As you say, it's very important, sir. Like they should be trained to have a cytopathologist.
What is the medium that you are using for cell block?
What is the
Medium that you are using for cell block?
No, he like alcohol and then hematoxylin using. We use strategy. We don't use fixed tape for
The medium, use formalin or
yeah, formalin.
or cytolate or which one? Formalin.
My pathologist say you send the material in formalin. What about you? Formalin?
So normally we just take it Nependoff and then he processes it. We take just dry Nependoff even for cell block, and they possibly use formalin later on. But we don't send it in any particular medium.
Nependoff is a vial. Nependoff is just the vial.
Yeah,
Okay.
it's vial. Yeah.
The plastic vial.
Yeah, same. Nothing added to it.
What is expectation for cell block is like cell block yield is as it is 70%, 70 to 75% even in the best of the hands. So, but these days, as you know, we need more tissue. If we have a lymphoma, they want to know what is the type of lymphoma, what is the subtype. So for that, they need material, immunostains. And if you are not able to provide diagnosis, then I think they will not satisfy. Oncologists are not satisfied.
But with acquired needles and clot biopsy, is cell block still relevant?
Yeah, so I'll show you the data. Antibiotic given. So histology is now coming to the way of, because we are getting good histological samples. So histology basically we get a preserved cellular architecture so that more ancillary studies can be done, more molecular profiling of the tumor can be done. So if you have a good histology, it can eliminate the need of on-site pathologists, and it will molecular marking, molecular profiling of the tumor can be done. So Dr. Bose, what are the different FNB needles?
There are multiple design needles available which try to take a core of biopsy, and like also with the FNA needles 19 gauge you can sometimes get a core biopsy. Core is what is required. For FNB we have new designs with this shark tip and this acquire.
And if the CO2 rises,
so
just let us
talking about it.
We might have to stop the procedure.
Just trying to show you the needles. This is the acquire needle, which is a Francine tip geometry, and then we have a pro core and we have a sharp core by Medtronics. So these needles design basically the acquire needle is it's a symmetrical beveled edges, crown tip, three beveled edges symmetrical. Pro core has a reverse bevel and it has a side slot, and you get tissue during the retrograde movement. And then this is the other one is the sharp core or fork tip. It's like a fork, 6 edges are there. So how to compare which needles do you do? Which needles, Dr. Reddy, you think all are same, or which do you think? I think acquire is available in India and Procore is available in India.
Yeah, I mean, there's no major difference. Actually, the technique which is important. There's no randomized control trial as of now, but I think all the needles work well.
Yeah, as the data has shown that Procore versus FNA, it's the same. Only thing is that you get diagnosis earlier, number of passes required is earlier. And then just, I want to highlight this trial where they, in the same region they used FNA needle, Boston Scientific Expect, and then they used FNB needle, acquire. And the amount of tissue you get, tissue volume was around 60 times higher, and the tumor area was around 40 times higher, and median area of desmoplastic fibrosis, the stoma which we get was significantly higher when they used the FNB needle. So if you have a rose, you will get diagnosed in one pass, that is okay, but that yield of, see the yield of diagnostic block, cell block, which we are talking about 60-70%, and even that they had 80%, and now with this needle they had 97.8%. So yield of cell block has significantly increased. Amount of material which we get during FNB needles, amount of cells, amount of cellular stoma, and amount of this is significantly higher. This side is the FNB needle and this side is the FNA needle. So it's a significantly higher FNB needle, the amount of material which we get. Among the other type of needles, Francine versus fork tip, it's same, whether amount of tissue, median number of passes, cell block adequacy, it was same. So now the question comes whether we can replace rows if you have a FNB. Now studies are coming up whether we can replace. So this is a study by Italian group, 333 patients we also had a meta-analysis of 1024 patients, and in the absence of Rose, FNB showed a trend towards better diagnostic adequacy. In the absence of Rose and in pancreatic lesions, FNB had better diagnostic adequacy, and there was no difference in diagnostic accuracy and optimal histological score. And another evidence for FNB is that they had 320 legions. Initially, they used FNA needles 2014-15, and now they switched over to FNB. So number of passes significantly decreased, and the amount of cell block adequacy which we are talking about to get the good diagnosis, it rose up to more than 90%, which was just 60 to 70% to start with. So this study also showed that diagnostic adequacy with or without on Rose was equal for both needles, but number of passes was less. And the main difference is this diagnostic adequacy on cell block. So it was significantly higher whether you use lymph node lesions, subepithelial lesions, pancreatobiliary lesions, all lesions. The amount of material you get for cell block is significantly higher with the FNP needle. So this article was published in memoriam, 5-needle aspiration, birth, 5-needle biopsy, the changing trend in endoscopic ultrasound guided tissue acquisition. So just 2 to 3 pass ESG recommends if you have a FNP needle. If you don't have Rose, if you don't have FNA, even if whatever comes you see, it will tell us with FNP needle whether it's adequate or not. These are, if you get material like this, it's adequate. This is equivocal and this is inadequate. So I'll just wind up because lack of time I've been told to wind up earlier. So we, for best practices, we need a cellular sample, adequate and needle. We use a 22 gauge FNP needle, preferably no suction, no stylet. We should fan the needle. And I think histology is the way to go in future. And because we need more accurate diagnosis, we get more diagnostic material for multiple profiling of the tumor as well as ancillary studies. And it includes the middle limitation in Rose because Rose is difficult to organize, even best of institutions, Rose is difficult. When FNP, I think we should not use in coagulopathic patients or cystic tumors, we should not use Rose. But Rose may still have a role because if you want to, in cases where PBS negative USFNP, difficult diagnosis, or when you are planning a therapeutic procedure like a pancreatic cancer, you want to establish resectable or you want to do drainage procedure, then you won't wait histology 7 days to come. You want on table to take the treatment, so then those will have say.
Hello.
Yeah, I think so. The only problem as of today for histology may be the cost. But I think more tissue, less number of passes, you don't need a very specialist pathologist for a diagnosis. So everything goes in favor of FNB.
Hello, Gaurav. Hello. Yeah, Gaurav, can you hear me?
Yes, sir.
Yeah, so we are ready with the case because it's already inside. We have started a poem.
Okay, Sandeep.
Okay, yeah. Sorry.
Sandeep, can we get the history of the patient? Sandeep.
Come up with the history.
Sandeep?
Yeah.
You have started?
Yeah, we have started. Just now we'll show you the history, follow the case has already started.
Just one sec. Now we'll have a live session and I would request Dr. Ruben, Dr. Prabir Rai, Dr. Kingsuk Das and Dr. Abhijit Sarkar to please moderate this session and yes, Sandeep, go on.
So this is a 36 years old male, is a diagnosed case of achalasia cardia type 2. He came to us around 2-3 years back. So the last dilatation was done in July 2017. So but the symptoms are persisting. Presently he lost to follow up for last few years to last one and a half years. Now he again presently with dysphagia. So we have planned him for poem. So over to Dr. Vikas Singla. So the case is done by Dr. Vikas Singla, and to allow me Dr. Vikas Singla, Dr. Bing, and Dr. Sudipta Dhar Chaudhary is there. So, Dr. Singla, you are on.
Ruben, can you see us?
Yes, yes, we can
Are
see
you
you.
audible?
Yes.
Yeah. So we are going to perform a poem in a patient, young male, type 2 achalasia, and he underwent dilatation 2 years back. Now he has recurrence of symptoms. The plan is to do a posterior poem. So in this case, I am fortunate to be assisted by king of poem, Dr. Bing. He is the real king. We have seen him today. And Sudipta, a very close friend, he will assist me. And Rajesh is there for any technical glitch. And Mr. Manali is a very able anesthetist. He will take care of anesthesia part. We have already inside the esophagus. Can you see the G junction?
Yes.
So there is some resistance at G junction. But we don't see any ulcer, polyp or growth in that area. So G junction is clear. There is no ulcer or tumor there. So this patient is having type 2 achalasia. So we will do 6 centimeter myotomy in the esophageal side and 2 to 3 centimeter in the gastric side. So can you see the impression of spine at 6 o'clock?
Yes.
And the spine is better seen in the actually proximal stomach. Once you go down.
So, Dr. Vikas. Dr. Vikas.
Yes, yes, yes.
So you have to decided to do a 9 centimeter myotomy for a patient with a type 2 achalasia.
Yes, yes.
So what is the length you choose for type 3 achalasia?
Type 3 at least 15 centimeters should be there. And you can also see the barium swallow film. And you can see actually in type 3 sometimes there is a narrow lower segment. So you can measure the length of the narrow segment in type 3 and you should always start above the narrow segment. So what's your take on that?
I think you should go by the manometry measures also. Look at your manometry and look at the point at which the spasmodic segment starts, and then you do it. You look at both the combination of manometry and the barium.
So Praveen, you can see that the spine is seen better in the proximal esophagus. As we go down, the esophagus goes away from the spine, the impression disappears.
Yes.
Because what do you think about going in and out of the lower esophageal sphincter repeatedly? Sometimes you end up with a bad mucosal injury with a cap on. So we should avoid going repeatedly.
Definitely,
to LES.
So Dr. Vikas, so what is the length for type 1 achalasia, length of myotomy?
Actually 1 and 2 it's the same, 5 or 6 centimeter. Type 3 it should be long. Even if you see the literature of the Heather myotomy, the surgeon are doing myotomy for the 6 centimeter, and in type 1 and 2 the response of Heather is very good. So the G junction is at around 45 centimeter and will start 10 centimeter above the G junction. So we are using the 23G injector. So first I will go in. So now I start pulling and Sudipta will start injecting. Inject. Nice. So now getting mucosal.
That's a very good bleb.
I think that's the essential part of starting the poem. If you don't get a good bleb, don't start the mucosal incision.
So how much injection?
20
amount?
20 ml is okay. Yeah. So now I will start the incision with the TT knife only. It's a TT gel knife. Yeah. So you can do the dissection and injection with the same knife. So first I will make a hole in the mucosa.
So Dr. Vikas, what do you think? Is there any difference in choosing about the different knives available? Because the beginners, it's always a problem, which knife to choose.
First I will go inside with the force current, force population. Force point. So you can see that I will go up to the that sure have cut the mucosa and the muscularis mucosa.
I think that is a very essential thing.
Out. Now I will lift and then cut. Parveen, can you see? Now you can see the submucosa. It means the depth of incision is good enough. Sometimes in beginning we don't cut the muscularis mucosa.
Do you, as Dr. Prabhi was asking, do you always use only the TTJ, or do you have another knife of choice as well? Or?
Other option is hybrid knife from the Arabic, but that's a costly affair. You need a water jet with that.
I think the choice between the knives is basically where your expertise lies. The advantage of the TTJ knife is theoretically it's single use, but it's easier to sterilize and reuse. While the hybrid knife from Urban, it's a little more difficult to reuse, and it should be used within a 24-hour period if you're going to do a 24 to 48-hour period. So if your volume is low, it's probably preferable not to use the hybrid knife.
Yeah, so because how commonly you see this sort of bleeding occurring during the time of incision? How common is this?
Maybe 1 in 10 cases.
It is quite common, Dr. Praveen. It's not very uncommon.
Yes.
I don't think we should be too worried about it. I'm sure because
it is more of an irritant rather than a problem, actually.
It won't affect you too much.
So here you want to stop the bleeding and then continue procedure, or you want to continue the procedure and let it bleed?
It's you can see there is spot actually.
I'm not seeing a problem.
Okay.
Settings are correct? Yeah, so
soft accumulation?
no working. Not working. Not working. No, it's slow. I know it's slow, but it's
working. All right.
So you're using a quack rasper here?
Yeah, we're using quack rasper and the soft coagulation.
Soft coagulation.
No,
yes.
FF4. That's it.
I think that's the point.
That's it.
Sometimes when we do the intern, we have some bleeding.
For a
beginning. Dr. Vegas, the incision intern, different I do. Yeah.
For a beginner, I think in a training scenario, a pig model would be
what is
ideal.
your thing,
The advantage is it would teach us depth of incision, understanding the submucosal plane, and
you think the
tunneling
incision is
myopathy. The disadvantage is there is no hemostasis training.
3 centimeters.
So a live pig is a little more difficult to do, but yeah. I think if you do a few pig models, it would be helpful. We did. We can say that we did use. But otherwise, if you can do supervised,
So for you now we are dissecting on the side.
A reasonable training model. So now we have switched to supervised poem rather than doing on pig model. So now the people who are learning poem are doing supervised poem.
So, Vikas, do you think this entry into the tunnel is one of the rate limiting steps?
Yes. For the beginners, yes. So first we have to dissect at the floor and at the edge, and we are making a space. You can see that we are cutting fibers on the side first. Then some dissection at the apex. Out.
People call this ledging. Basically, they cut under the sides so that there's more space in the submucosal.
Now we are inside the tunnel.
Yeah, very nice.
Out. Now the dissection should be close to the muscle layer. So at lower side is the muscle layer, and our dissection should be always close to the muscle layer. So Parveer, I am moving from one side to another side.
Yes, very nice.
And yesterday Rubin was using the spray coagulation. But today we are doing it with the force coagulation. Spray can you do it from a distance, but force you have to touch the fibers. So Lisa, what's your take on the current?
I use the spray coagulation, but what if you're using the forced coagulation? I think with the spray you can do a much bigger areas quickly.
Yes.
But
you can see a vessel
there. Yeah, there's a vessel there.
So these vessels with the spray, I would have just taken it off.
So you are a daring man. So this vessel, either you can do, I think it's a larger in size, slightly bigger actually, Sudipto.
Yeah, this is a bit bigger.
Yes.
You can use a co-graph.
So, but Parveer, if it's a smaller vessel, you can directly do with the force coagulation. But it's a slightly larger in size.
Sometimes it's safe to use a...
Yeah, so I think better to use a soft coagulation with the co-graph.
So is there any size criteria? What is large and what is small?
Actually, there are no objective criteria, but just with the experience you can see that. So I will show you smaller vessel also, where we can tackle directly with the...
So a rule of thumb is the shaft of your TTJ. If it is larger than the shaft of the TTJ, then it's probably safer to use a co-grasper. And if it's smaller than the shaft of the TTJ, go ahead and use your dissecting knife.
Yeah, which comes to around 3 millimeter or so. That size.
I think you cannot make that.
3 I think is too large.
3 is a big vessel.
Okay.
3 is an art.
We don't see 3 mm vessel in the...
Okay.
So initially soft coagulation, then you have to cut in the last. So at the upper side is the mucosa with the submucosal fibers, and on the lower side you can see the circular muscle fibers, and we have to be perpendicular to the muscle fibers. Color is bit different actually, it's a more purple color. We are used to more of sky blue type of color.
The
injection, right?
Yeah, color of the submucosal fibers, yes.
This is the sky in Kolkata is this color.
Okay, this color, okay. And fortunately today we don't see much fibrosis.
This cap is also tapered?
No, we are not using, we are using a routine cap. And when you are injecting, you can see that the knife should be in the closed position. So when you are injecting, the knife should be closed, and during dissection, the knife should be open.
There's something on the tip of you can't do dissection with close. Natural fire karega.
It has to be.
Okay, give me something to clean the knife. Come, we have brush. So 1 minute.
And this is charring at the tip of knife, so we have to just clean it. Yeah. Dr. Parveer, Dr. Ruben, any question from the audience?
Yeah, so any questions?
Any questions? I think everybody is just mesmerized by the really nice dissection that's going on. Yeah, speechless.
Yes.
Actually, it's Sandeep has given an easier case for me.
He likes you.
He has more faith in you, that's why he gave you a difficult case.
But you can't predict. Some are good, some are not as good.
Absolutely.
No, you can never predict till the last thing is done. It's like the colonoscopy.
Like ERCP.
You don't know when till the last, till you have closed the tunnel, you don't know what surprises can hold.
Yeah. Sometimes even the closure can be difficult. We have spent, at least many patients even spend 2 hours closing the tunnel.
So sometimes you don't know where your surprises lie.
Okay. Out.
So.
Hello, Ruben, can you hear me, Ruben?
Yes.
Ruben, when they are in the tunnel, so here we have come with another US patient, diagnostic US. So the history is she's a 26 years old female.
Okay.
Can you hear me, Ruben?
Yes, we can. Go ahead.
Yeah, so 26 years old female. She was operated for pheochromocytoma in 2016, and also she had a bleed, probably because of the malignant hypertension, and she was operated for that. And now she has a large incisional hernia at the site of the abdominal surgery. So when CT was done for that repair, the surgeons, they found out there are multiple cystic lesions in the pancreas. So our idea is to do a diagnostic US. Malay sir is doing the case.
Okay. Thank you, Dr. Vikas. We'll come back to you. They're just deflating the stomach.
We need another knife. This knife is not working.
2 to 3 cases.
Now do it.
Co-grasper works for eternity. Till it breaks, so you do something. Sir, we can't hear you. Can the audio be turned up? Dr. Malay?
Yeah. Can you hear me now?
Yes, sir.
Okay. So what we are seeing now is the portal vein. And this is the superior mesenteric vein. This is the splenic vein. And this is the portal vein. And this portal vein is dividing the pancreas into 2 parts. One is the body part, which is above, and one is the head part, which is below this. Now we have to find out where it is. So as I rotate clockwise, I didn't find any cyst so far. As soon as I rotated anti-clockwise, I found a cyst. This cyst is at the junction of the body and the neck part of the pancreas. As I told you, this is the body part and this is the head part. This is the cyst here. So we'll further characterize this cyst, but let me find if from the stomach I can find any more cysts or not. So I have not found any more cysts. Now my questions are: is this cyst communicating with the pancreatic duct? That's one question. Second thing is, are there many cysts? And then we start working. So there is not one cyst. There are many smaller cysts, and these smaller cysts, if I were to freeze and take caliber, they are of the diameter of around 5 millimeter, and the bigger one is of a diameter of around.
Sir, when would you call it microcystic, or when would you?
No, they are not connected to each other, because this, as I rotate here, they are disappearing. This has got no connection to this. So I will say this is not a part of a single cyst, they are multiple cysts. But now you can see this cyst quality imaging needs to be improved. I am increasing the frequency here to 10 megahertz, number one. Number two, I am applying compound imaging. Number 3, I am applying tissue harmonic imaging. Because the ingoing frequency is 10, and now this frequency button will change to tissue harmonic. It will become 20 megahertz. Then I am wasting my energy because I am seeing 5 centimeter. I will change this depth to 4 or 3. Then lastly, the focus. These are the focus buttons. They are focusing on this cyst appears and disappears. So there are multiple, and in this field, so there are 1, 2, 3, 4, 5 cysts. Okay. So these cysts are not communicating with each other. So now I have to try and turn clockwise, and as I said, I rotated it clockwise, and now I am trying to see the tail of the pancreas, and in the tail of the pancreas, is another cyst. This cyst has got a more well-defined.
We can't hear you, sir. No, the audio seems to have been lost.
Yeah. Now?
Yes.
So now we are finding a cyst here in the body, and this part is in front of aorta. So we are coming as we are rotating. This is the body of pancreas, and as
No, the audio is not working.
so now we rotate here, and as we rotate here now, this is the cyst in the body going towards tail of pancreas. Can you hear me now?
Yes, sir, we can hear you.
So this part is going toward tail, and I am going all the way toward the tail. So till part, and I am going, my job is to go all the way to the hilum of the spleen. And as I went toward the hilum of the spleen,
I found 3 more cysts within the hilum of the skin. So my mapping has so far shown, because this pancreatic tail is again a solid bunch of neck, and what you would have said, that I would have called it some sort of a serous cyst adenoma if I was being allowed to see, or only because here these cysts seem to be in communication with each other. Here they are in communication with each other. This is the disease or not. Can serous cyst adenoma be multiple or not? Okay, so that I don't know. But this is, again, these cysts, isolated in isolation, maybe I would have called it a serous cyst adenoma. But then what would have required is, because in between these two, I am finding within these septa there is some flow, and this is an important part to confirm that benignity, relative benignity of these cysts, that these cysts are relatively benign, because in the wall in between the cysts there is vascular, and serous cyst adenoma, the presence of internal vascularity within the cyst is a so this is wall cyst, blood flow near the wall. So the septa are perfuse septa, hypervascularity. Even when I apply color here, you can see some color signal even here in between two cysts, two very close adjacent cysts.
Sir, just a question. Would the cyst, question one, would the cysts in a serous cyst adenoma be so large usually? Two,
they will not be so macrocystic.
Yeah, and two, when there's such a doubt and you said that the vascularity is good, would sono view or a contrast be helpful in this scenario?
It will help. It will make it all the more vascular. It will make it all the more vascular in this instance. So we have seen the cyst in the tail, we have seen the cyst in the body, and finally we are left to see whether the cyst is in the pancreas. Only question that I have not been able to answer so far is, but does this cyst seem to have a good communication within the pancreatic duct or not? The problem is the answer to this question, because so many cysts cannot be communicating with the pancreatic duct and all.
Malay, this is Kinshukuya. So can you connect the past history of pheochromocytoma? There's nothing, I think these are all separate?
Kinshuk, I am a very weak theory person.
Yeah, no. You are the master of this. I know since 2001 we traveled together when you started learning US. So listen, is there? Can you from the your vast experience that really there is something?
Kinshuk, let me complete my sentence.
Yeah.
Can we make the table higher? What happens? There is only one disease that I have listened, that is von Hippel-Lindau disease. So my knowledge of the syndromes and all that Sandeep Pal thrusts at me is very limited. So that is why I said I am a very weak theory person, and as soon as I end up in some sort of unfamiliar ground, I start scratching my head like the way I am doing right now. So I have no diagnosis. My theory is very weak and I don't see such kind of cases. But I can only discuss about the syndrome and all is beyond my capability. My capability is to present to you, to the audience, that this is what we are seeing. And some logical base. Beyond that, I don't have any. So now I will again try how to introduce into the duodenum. You turn whole body to the right, and whole body to the right. Keep on torquing, and in this case, slight push-in. See, the probe is now seen at 6 o'clock, and you will cause perforation if you push. So I am rotating my whole body to the right to enter duodenum, and it is not must that I should, but here is where slight push it in, moving up knob all the time up knob up, and again moving right and left knob. So the trick is not to push. Sometimes I am so close, I am moving whole body, right and left knob, and again slightly pushing or pulling, but trick is not to be too much in a hurry. Now I am pulling, I am almost blind because this is, but I am slowly pulling back. This is part of blind, I don't feel comfortable, I should, but I am moving my whole body slightly. The mucosa is sliding,
and I am sliding, and this now I have been able to. So sometimes when you have deformed duodenum, you will end up with these kind of entries where you are partially blind. Okay. So now I have entered the second part of duodenum, and now I am going to imagine two things I am going to look. Can I identify the pancreatic duct? No, I cannot. Till now I have not found, but I start looking for it higher, and I have got a very smart person with me. He keeps on storing whatever is important in me. Okay. So now rarely I use this position, but since I am trying to show with my hands off, I use this type of position, but this is abuse of endoscope, and that is, so we now are seeing, now there is a cyst in the head. Now is the question to see how to, if I rotate like this cyst disappears, and there is another cyst appears. If I rotate like this, I am now trying to see if I can find the pancreatic duct or the bile duct, but I have not been able to find pancreatic or bile duct so far. So, okay, so I will pull it more, and see if right now I can identify here. No, and till now again no bile duct, no pancreatic duct so far. So this is now I am withdrawing more, because now aorta is at an angle, and now what you are going to see in between aorta and this part is the uncinate process, and here is where I expect the papilla to come. Now I am rotating more anticlockwise, moving up now above, and moving and expecting the ampulla to come, but I could not find it, and I may have slipped out. So I will not, yes, I did slip out. So in this process of slipping out, I found out that there are several cysts in the body, and this cyst that I am seeing is the same cyst that I had mentioned near the neck of the pancreas while we were going in. So we have another last technique, and that is to go into the duodenal bulb, and this time without entering the descending duodenum, try to imagine the neck part from the duodenal bulb. So now we are in the duodenal bulb. I am decreasing the depth and now turning my whole body to left and to right, because one of my main job is to map the cyst, how many cysts are there, that is, and my second job is after mapping the, so here is for the first time I have found a pancreatic duct, and to me this is the pancreatic duct, and this pancreatic duct does not seem to be in any association with any of them.
Sir, so they have reached the G junction.
Okay.
So I would like to tell, we have done MRI for this patient for the pancreas. So there they have reported as this simple epithelial cysts, and we have done tumor markers also for this patient. The blood serum markers, CA 19.9, CA 125, all these are normal.
Sandeep, one question.
Yeah.
So do you have access to SonoView?
Yeah, we have here.
Okay.
So
because what the in one hepatidindo, if there's pheochromocytoma,
yeah,
there's a possibility of neuroendocrine tumors as the solid lesions.
No.
And which is not, obviously, I'm not saying this is a solid lesion.
Yes.
And macrocystic, which is very unusual, macrocystic serous adenomas of the pancreas.
Okay.
So if you give SonoView and the septa become very bright, then you may have the diagnosis, and but if you've already done FNA, you don't need to. But these
no, we have not done FNA. We have not put a needle in this patient.
Okay.
No need.
So this over to Malay sir. He says,
you want, what do you want?
Like, is it indicated to use SonoView?
No, I don't think. I think in this case I will be happy. So there are some people who are used to do contrast day in and day out, and in workshop many of them would like to use SonoView and all this. But in this case, there will be.
So what is your conclusion? Like this is a simple cyst?
Like I think multiple simple cysts in the pancreas.
Okay. Thank you. Ruben, we'll move to the other room. Thanks, Malay sir, for the wonderful demonstration. Dr. Vikas, you are on.
Yeah. Out. So we are at the G junction, and this is the narrowest part. And you have to be very careful at the G junction, otherwise there can be a mucosal injury.
So, because what are the points to say that this is the G junction?
No, tunnel is getting narrowed here.
Okay.
And we are still not inside the stomach, we are in the esophagus, but the tunnel is getting tight and we are facing a lot of resistance here. Okay.
So you start suspecting G junction when the tunnel becomes narrow and the area is limited.
Yes, yes.
Yeah, having said that, Dr. Pravir, we should also keep the numerics in view because certain areas where fibrosis.
No, Sudipto, your voice is not clear.
What he said was they should keep in mind the numerical value that they had got with the cap of where the G junction
Because
is.
sometimes the fibrosis can mimic areas of narrowing.
So if there's fibrosis proximal to the G junction, with somebody who's had dilatation,
No,
in the
force
past,
formulation. Force.
that could mimic that could mimic the G junction's tightness as well.
Go down, this one, go down.
So I think to identify while they're discussing, to identify the G junction, there are numerous methods